Today's session is themed Silent Threat Understanding Meningococcal Infections. To begin, let me invite the esteemed chairpersons for today's session, Vidya Jyoti Professor Prasad Katlanda, President of Ceylon College of Physicians, and Dr. Vimalasiri Uluvattage, the convener of Infectious Diseases Forum, Ceylon College of Physicians. I invite Professor Prasad Katlanda, President of Ceylon College of Physicians, to give the introductory remarks.
Good afternoon. Dr. Vimalasiri Uluvattage and Dr. Nilanka Pereira of the Infectious Disease Forum of the Ceylon College of Physicians, other members of the CCP, ladies and gentlemen. Let me welcome all of you to the second Infectious Disease Day of the Ceylon College of Physicians, conducted along with the Infectious Disease Forum. And this is a series of programs where we are going to enlighten the physicians and all other doctors on different infectious diseases and different aspects of infectious diseases. Today, the theme is Silent Threat, Understanding Meningococcal Infections. We are going to have an initial plenary lecture by Dr. P. Vishnu Rao, Consultant, Department of Infectious Diseases, Apollo Hospitals, Hyderabad, India, on meningococcal infections. He will set the stage for the deliberations, which will be followed by a case-based discussion, where cases will be presented, and we have a moderator, Tisra Pereira, acting consultant physicians at the National Institute of Infectious Diseases, with the panelists being Dr. Vishnu Rao, Dr. Suranga Manilgama, consultant physicians, National Institute of Infectious Diseases, and Professor Lalindra Gunaratna, professor and consultant hematologist, Faculty of Medicine, University of Colombo. Let me hand over the proceedings to Dr. Vimalasiri Uluvattage to introduce the first speaker.
Thank you for that. So I do the present task of introducing Dr. P. Vishnu Rao. He's an infectious disease consultant working in the Department of Infectious Disease of Apollo Hospitals, Hyderabad, India. With several years of experience in the field, Dr. Rao has established himself as a trusted healthcare professional dedicated to the diagnosis and treatment of complex infectious diseases. He holds multiple prestigious qualifications, including an MBBS, MD, and FNAB in infectious diseases, along with certifications in CICK and DRC-PATH, showcasing his commitment to continuous learning and expertise in his specialty. He was a visiting fellow of Wayne State University, Detroit, USA. Dr. Rao focuses on delivering tailored healthcare solutions, employing the latest advancement in the diagnosis and treatment of infectious diseases. He has held the post of Head of Hospital Infection Control Committee and Chairperson of Antimicrobial Stewardship Committee, Yasoda Group of Hospital. Over to you, Dr. P. Vishnu Rao. Thank you.
Thank you, sir. Thanks for that kind introduction. Good afternoon, everyone. Let me share my screen. So today I'm going to speak on meningococcal infections, what clinicians need to know. So essentially, I'm going to give this lecture on the following headings. So right from the introduction to the epidemiology, then risk factors, pathogenesis, clinical features, diagnosis, treatment, and the ounce on prevention. To begin with, coming to the basic stuff about the, I'm sorry, one second, I'm just not able to. I'm sorry, just give me 1 second. Yes. So coming to the introduction, Meningococcal meningitis is caused by a bacteria called as Neisseria meningitis. It is basically a gram-negative diplococcus. And the transmission, it occurs only in the humans. It spreads via the respiratory droplets, and also 3 to 25% of the normal people have asymptomatic carriage. So significant of us have asymptomatic carriage. And you have, it is divided into, basically, it is caused by a bacteria called Meningococcus, and it has various serotypes like A, B, C, W, X, Y, which actually have capsule, and they are the one which is required for the phagocytosis. They are the one which is required for the virulence of the organism and inhibits the phagocytosis and causes the disease. And it also has other virulence factors like type 4 villi and outer membrane proteins, which I'm going to show you, which help in the virulence of this particular organism. Now, coming to the basic cell structure, this is a gram-negative diplococcus, and you can see here, this is from inside to the outside. Coming to the basic stuff, this is called capsule, which is the outermost covering here, and this is the one which is responsible for the virulence of this organism. So essentially, this inhibits the phagocytosis. Now, this is the capsule. And now what you have is here is the outer membrane, and you have a periplasmic cells, and you have a cytoplasmic membrane. So this is the outer part of the meningococcus. And here it has something called as lipoalgosaccharide. This is the one which is the endotoxin and which is responsible for all the problems caused by meningococcus. So it acts as an endotoxin, and it causes damage to the endothelium and third space losing, and causes inflammatory, beginning of the inflammatory cascade, and that is the one which is responsible for the pathophysiology of this particular disease. Now, based on the capsular polysaccharide, it is divided into serogroups, which is called ABC, WXY. There are total 12 serogroups, but only 6 of them are pathogenic to the humans, and of them are ABC and WXY. And it also has here outer membrane proteins. These outer membrane proteins, they help in adhesion and evasion of the immunity. And it also has certain proteins called iron proteins, through which it depends on the host iron for its virulence. So this is in gross about the basic pathophysiology. Now, when you read about meningococcus, you also see about all this terminology, the serogrouping and the clonal complex and the sequence typing. This is all the terminology you study in books. So what essentially are the basics? So basically, as I told you, based on the capsule, they are divided into ABC and WXY. And this is the capsule-based classification. You also see something called as genetic-based classification, where they use terms called as clonal complex and sequence types. Clonal complex is nothing but they are the genetically similar strains, which are basically grouped based on the 7 housekeeping genes. And in this clonal complexes, based on the variation, you sequence them. So you call them ST. There is sequence types 11, 12, etc. So basically, serogroups A, B, C, W, X, Y are the capsule-based classification, and the other is the genetic-based classification. Now, coming to the epidemiology. So global burden, almost you see 500,000 cases per year with 10% mortality. The overall case fatality rate is around 15%, and it is decreased compared to from the early 2000s because of the vaccination. Now, disease pattern occurs in epidemic, outbreak, or hyperendemic regions. Now, these hyperendemic regions typically we see in the meningitis belt in the sub-Saharan Africa, where the incidence is very high, up to more than 10 per 100,000 cases. And also these outbreaks, they typically occur in the multi-recruits or the daycare centers, where the increase in the number of cases in a closed areas. Now, the epidemic regions are mainly the sub-Saharan Africa, where you have these serogroups ACWX, and globally it is group A epidemics that happens across the world. Now, the outbreak clusters, outbreaks are nothing but which occurs in the host community. They typically linked to this serotype 11 clone, typically belong to the BCW serogroups. Typically, in the close communities, what you get in the multi-recruits or in any colleges and all, you see this is particular thing which we are seeing. And also in the Hajj outbreaks, especially if you see somebody going to Hajj, in fact, the recommendations are to give meningococcal vaccination because of the overcrowding, and because of which you can see meningococcal infections. Now, if you see across the world, in US, it is BCY strains, and it is in the South America, it is BCY. In the Africa, AWCX. These are the strains that are there. And if you see in India, we have more commonly A. And I tried to look in the Sri Lankan data, what is the serogroup that is available, but I couldn't get the data. Now, what are the things that is happening across the world? As I told you, it is in the meningitis belt. It is we call hyperendemic cases, where the cases can go up to 1,000 per 100,000. Per 100,000 people. So it can be as high as here. It typically extends from here to Senegal to the Ethiopia. So this is called the meningitis belt. And this is the area where you have higher number of the meningitis cases, and they occur in the hyperendemic. They're hyperendemic because the cases are way too higher there. And if you see in the Australia, Europe, South America, it is basically these are the strains. BCWY are the strains you see. And if you see in the Hutch pilgrims, what we had was serogroup W. Now, in India, this is the data. In India also, we don't have much of the data, but based on one of the meta-analysis what's available, it is typically, in all these meta-analysis, they looked into the cases which occurred in epidemic and the endemic cases, and they tried to come up with certain numbers. Here, the prevalence of acute bacterial meningitis during the epidemics is up to 12%, and the case fatality rate was 12.8%. Mind you, the global case fatality rate is around 15%. And when it is endemic or when it occurs in sporadic, the case fatality rate is only 3.6%. And typically in our country, what we had was in the Delhi, Meghalaya, and Tripura, the outbreaks happen, and primarily it is serogroup A. In other regions, it is ABY. Now, one of the things what we observed in our outbreak in India is that the fluoroquinolone's resistance is as high as 65 to 100% here. It is way too high. In fact, the reason why am I telling is that one of the option what we have for prophylaxis of the contacts is fluoroquinolones, but here in India the resistance is way high and we don't use it. And in fact, few of the cases in Delhi outbreak we even saw ceftriaxone resistant, but most of the times it's ceftriaxone sensitive. It is working very well, but ciprofloxacin resistance is way high for us. And now I tried to look into the data in the Sri Lanka. I could come up, in the literature review, I could find this is the one which is the biggest case series present in Sri Lanka, which is a cluster of 12 cases. This was published in 2021. And here the mortality rate was 36%. And here, good number of cases are actually, if you see that around 4 or 5 cases are from the prisoners, from the prisons. So basically, as I told you, the risk group, one of the risk group for meningococcal is presence of overcrowding. And also high density population, high density where the overcrowding is possible. This is where we typically see, and whatever the outbreak that happened and that's been described, it is particularly happened in the prisons and in the high density setting. And here they couldn't do the zero grouping here. So that is one of the things. So we don't know what zero group is there in Sri Lanka. And the good thing is that, all are sensitive, at least, you don't have much of the resistance in the cases that has been documented, and the mortality was 36%, which is little higher and is expected when new cases occur. It takes time to understand what is happening, and obviously initially the mortality will be little on the higher side. Now, what are the risk factors? The risk factor, the extremes of age group are at risk, that is infants less than 1, and also in the teenagers. Teens and young adults are also, they have the increased risk, and the highest risk is in the under 1 year of age groups. And you can see in the older adults, increased susceptibility. And the other medical conditions like complement deficiencies, we call terminal complement deficiencies, because these complements are required for the, which is one of the main immune mediator mechanism for us. In the complement deficiencies, we see that. And splenectomized patients, somebody who has asplenia or functional or anatomic splenectomized patients are at risk. And HIV also, HIV and low CD4 also keeps somebody at risk of having meningococcal infection. And complement inhibitors, now that, they're using new drugs like, eculizumab for paroxysmal nocturnal hemoglobinuria, where it breaks down the complements. So in fact, when somebody is on eculizumab, the terminal complement inhibitor also increases the risk of meningococcal infection, and where this patient typically we give meningococcal vaccines. And also close contact. Somebody who is close contact, the close family members are at 500 to 800 times increased risk of getting a invasive meningococcal disease from the infected person. Now, the other setting, as I was telling, the overcrowded conditions like college students, military recruits, and travelers to the meningitis belt, and also Hutch pilgrimage travelers. These are all the particular risk group settings, specific risk factors where you see the increased incidence of meningococcal infection. Now, coming to the meningococcal carriage and the disease, mind you, 10 to 35% of the young adults, and in the closed environments, even up to 100% of the people are colonized. But mind you, not everybody that colonized doesn't develop disease. So most of them are asymptomatic, and the incidence is 1 to 1,000 per 100,000 population. And why it happens? Because it has to be two things. One is the host, the other one is the one is the pathogen and the other one is the host. And host hypervirulent strains and somebody with capsule expression. Mind you, in fact, if you see the data, out of all these colonizers, in fact, 50% of the isolates are actually doesn't even carry a capsule. So they don't even cause any disease. And also there are certain strains like ST11 or 32. These are the ones. So the hypervirulence and the genetic predispositions, not only not only the virulence, it also the genetic predisposition that is required for somebody to develop invasive meningococcal disease. So the complement deficiencies, age, smoking, and the risk factor, what I have told you, and with the virulence pathogen can lead somebody to develop an invasive meningococcal disease. Now, the pathogenesis. So basically, there is high carriage in the adolescence. As I told you, there are certain proteins which will help in invading the organ, is invading us and also evading our immune mechanism. And there's a capsule which prevents phagocytosis and which is essential for invasiveness. On all the capsule variants, I said A, B, C, W, X, Y. That's the reason. The capsule is something which inhibits the phagocytosis. That's the main crucial role. Invasion, as I told you, it is rare, but it happens when the host and when the bacteria is when the virulence is high and with all the genetic predisposition I told you. And once somebody it invades, it causes inflammatory response. As I told you, the lipopolysaccharide, which is present, and I have shown you, that is the one which triggers the cytokine cascade, which causes the release of IL-1, 6, and TNF-alpha. And that is responsible for the inflammatory response and the manifestations what we see. Endothelial injury, this lipopolysaccharide, it causes vascular leakage, it causes damage to the endothelium, it causes damage to the endothelium, and it causes third space losing, and also it increases the production of tissue factor, and that itself causes a lot of procoagulation cascade, and it causes a lot of coagulation, and that's the reason you see all these gangrenes and amputations in this particular cases. Now coming to the shock and organ dysfunction due to the hypovolemia. Because of the hypovolemia is what you see the hypovolemia, myocardial depression, and tissue hypoperfusion. You see shock and organ dysfunction. Now meningitis, the local inflammation causes cerebral edema and raised ICP and neuronal injury. Now this is the a simple flowchart which I try to show whatever I have told you till now. So initially you have colonization, asymptomatic carriage, invasion is rare, and once it invades, it enters the blood, and it activates the immune response. The endotoxin activates IL-1, IL-6, and TNF-alpha. The endotoxin releases and causes inflammatory cascade. And that causes, if it's in the meningeal space, it causes meningitis, cerebral edema, and neuronal injury. And if it's in the blood, it causes meningococcemia, endothelial damage, coagulation abnormalities, thrombosis, and purpura fulminans. And it causes capillary leak and cause shock and organ dysfunction. So endothelial injury, capillary leak, shock and organ dysfunction, and coagulation abnormalities, thrombosis, and purpura fulminans. And if it is in the meningeal region, of course, meninges is a closed space. The subarachnoid space is a closed space, and where you can get all these inflammatory things. They can they can cause raised ICP, they can cause cerebral edema, and cause neuronal injury. So this is in simple. So the transmission, basically, it occurs from person to person by something called as droplet mode, where droplet means these are the large particles which carry only up to 1 meter distance, and so hence the direct contact and close people only get this one. And mind you, not everybody who get the disease. 99% are asymptomatic. They don't have any problem, and less than 1% have the invasion. And whenever it invades, it can cause meningitis, meningococcemia, and other uncommon things like septic arthritis and purulent pericarditis. And it can also rarely cause mucosal infections like pneumonia, sinusitis, urethritis, proctitis. These are uncommon manifestations. And as I told you, it happens to transmission, crowding, close contact, smoking and respiratory co-infections can all increase the transmission rate. And the carrier is 40% has transient carriage, and up to 5 to 25% of the people even have a prolonged carriage. Now, coming to the clinical manifestations, the commonest clinical manifestations of what we see is meningitis, which occurs in 40 to 64% of the invasive meningococcal disease. So up to 40 to 60% is aware. And typically the patients present with fever, headache, altered mental status, with or without rash. Mind you, the rash can present only in 26 to 50%, 60%. That means half of the time you may not see the rash. And when the rash is present, it is often petechial but less extensive than in septicemia. Mind you, in septicemia, you see florid rash, you see this purpura fulminans very common. In meningococcal rash, at times the rash may be faint, you may see mild petechial rash, so examination is the key. And one of the key points is that the rash typically goes to palms and soles. This is one of the differential for those rashes which cause on palms, so always examine palms to look for these petechial rashes. And neurological findings, obviously, they complicate. You can get focal deficits, seizures, cranial nerve paralysis, raised ICT, cerebral edema, and of course, death and hearing deficits. All you can get because of the complications. Mortality is 5 to 18%, often due to the cerebral edema and brainstem compression. Now, the diagnostic findings is obviously it is the neutrophil predominant, low sugar, high protein meningitis, typically what we see in the bacterial meningitis. Now, the next one is the meningococcemia. Meningococcemia is nothing but is a direct bloodstream infection causing, or meningococcal septicemia, because of the direct bloodstream infection and causing hypotension, adrenal hemorrhage, and causing the issue. So now this occurs in 10 to 20% of the meningococcal cases. Mind you, 40 to 65% are meningitis cases and 10 to 20% are the direct meningococcemia patients, and most of these patients may not have a coexisting meningitis. So they present like community acquired sepsis syndrome. They present with just fever, cold extremities, hypotension and florid septic shock. One of the key things, one of the clinical points, although non-specific, is severe muscle tenderness and myalgias present in this patient. And you can see here, within 12 hours, the patient comes for admission. And so such a rapid in onset. And in these patients, if they have rash, the rash is present here in more number of patients, up to 40 to 80%. And one of the key thing is that this rash progress in front of yours within few hours to few hours, the rash progress and involved throughout the body. So once you see the patient now, and within 2 to 3 hours, the rash just progress rapidly in front of eyes. And this is one of the clinical clue for you to think of meningococcus. And as I told you, this is a septic shock, meningococcemia, where you can get shock, you can get DIC. There is a lot of bleeding, organ failure, and there is adrenal hemorrhage. We call Waterhouse-Fredrickson syndrome, where it is adrenal hemorrhage. And also, as I told you, there is this tissue factor activates, and there's a lot of coagulation cascade going on. It can cause thrombosis of the various organs, and late complication, it can cause necrosis, and it can cause vessel occlusion, even cause digits loss, or limb amputations because of the coagulation. Now, few patients, they can even have a mild or transient bacteremia. It occurs in less than 5%. The mild febrile illness often mistaken, and just patient recovers. It is somebody who is lucky that, this is probably happens because of any of the mutations in the endotoxin. They may just have a transient, self-resolving illness also can occur. And mortality is very high in these patients. Rapid progression, even death, occurs within hours. Now, so how does the rash look? See, the rash of the meningococcal, initially, it just looks as a fine rash. It ends, in fact, the differential, they give it as rubella. You can see the fine pinpoint, petechial rash you can see here. And you can see these are non-blanchable. They don't blanch on pressure. So non-blanchable rash, petechial rash, the initial manifestations you can see here in the images. And once it progresses, it can cause the, hemorrhages or cutaneous ecchymosis kind of picture, which we typically call as purpura fulminans. You can see here purpura fulminans. And as I told you, the rash typically involves palms. One of the key areas where you observe is the palms, where you see in this particular cases. Now, the next thing is a cutaneous hemorrhage. As I was telling you, the cutaneous hemorrhage causing Waterhouse-Fredrickson's the cutaneous hemorrhage causing purpura fulminans here. And here you can see the complete digit amputation, the ischemia of the digits, which requires amputation. And you can see here the adrenal hemorrhage. You can see the adrenal hemorrhage here. Now, this is the NICE guidelines, which ask you to look for this particular things when you think of meningococcal meningitis. The red flag things, what we see is that somebody has a hemorrhagic rash, hemorrhagic rash, which purpura, which is progressing and spreading. Somebody who has meningitis, you need to think of this case, this particular patients. And typically these patients has one of the few non-specific things which may help, the leg pain or the cold hands and feet. Although these are non-specific, they essentially says that this patient, they present very rapidly, and they have features of septic shock initially. And what helps clinically is the presence of that rash, especially during the time of epidemics. Now, the chronic, there are certain other uncommon manifestations like, complement deficient, chronic meningococcemia, where you see intermittent fever, rash, joint pains, and may progress to meningitis. Mind you, these are not common. You typically see in somebody who has a mutation to the endotoxin, where the endotoxin won't be as effective, as bad as what we see in the meningococcemia. There is a purulent pericarditis, septic arthritis when it can involve the knee and ankle, pneumonias typically with the serogroup Y, conjunctivitis, and one of the new interesting things, because I see a lot of STDs, we are seeing the other described entities, the urethritis and proctitis, because MSMs, they tend to indulge in the orogenital sex. Even meningococcus can cause urethritis and proctitis. This is an upcoming entity. And certain immune-mediated manifestations and long-term sequelae, you can have, limb loss or hearing loss, and the case fatality rate is 15% overall.
Your
now,
time is
the differential
up.
diagnosis, if you,
Dr.
I
Rao,
just
your
finished
time
it.
is
I'm
up.
sorry.
Okay.
Yeah, just 1 minute. I'll just finish it off. The differential diagnosis, please think of, you have dengue rashes, dengue can look similar. And one of the other thing is the Indian tick typhus, we call a Bontinus fever. Even the rash looks exactly similar like this. And one of the other thing I wanted, this is my fresh case, which I have in my option, chikungunya. Chikungunya can present like encephalitis in elderly, and the rash at times mimic exactly like, meningococcus. Please keep this in mind. And this is other chikungunya rash of my cases. This is other differential. And the diagnosis is by, CSF analysis is typically low sugar, neutrophil predominant low sugar meningitis, and the drug of choice is ceftriaxone. And alternatives what you have is moxifloxacin and chloramphenicol if you have any allergy. And mind you, because of the severity of the disease, there are other things that was studied, and the only role is for corticosteroids, which if the patient has adrenal suppression. Otherwise, the other, like, activated protein C and all, none of them help. And for high risk context, you give prophylaxis, typically the close contacts, and for doctors who intubate them, who had done secretions, who had drained the secretions, those are the people who requires prophylaxis, and typically rifampicin, ceftriaxone, and ciprofloxacin has been used. And for vaccination, for high risk patients, we have conjugated and unconjugated vaccine. Typically, typically the patients what we give is splenectomized patients, or somebody who is on eculizumab, who's traveled to Hajj, and during the time of outbreaks, you have this Menacra, the conjugated vaccine that help. I think with this, I'll end my talk. Thank you. Sorry that I'm a little bit late. Yeah.
Thank you very much, Dr. Rao. That was a very informative talk. And let's move on to the case discussions. I think we can take up the questions during the case and after the case presentations, perhaps, because the time is past. And let's move on to the case discussions.
Now, it is my pleasure to invite Dr. Thisara Pereira, Acting Consultant Physician at the National Institute of Infectious Diseases, to moderate our case-based discussion.
Good afternoon. We are going to discuss two interesting cases related to what Dr. Rao has spoken about, two varying presentations. For that, I cordially welcome on stage. For the expert panel, we have Dr. Vishnu Rao, who is the consultant ID physician from Apollo Hospital, and we have Professor Lalindra Gunaratna, professor and consultant hematologist, Faculty of Medicine, University of Colombo, and our very own Dr. Suranga Manilgama, consultant physician, National Institute of Infectious Disease. Dr. Suranga Manilgama will also be joining us online. So I will start the first case. Both of these cases are from National Institute of Infectious Diseases, and for all the pictures and the case details, we have taken the consent from the patients. So the first case, we have a 29-year-old man presenting with fever and rash. So he's a previously healthy unmarried person who is a prison guard who is working in Colombo. So he presented with fever for 1 day, and he developed a macular papular rash along with the fever, which was predominantly in the peripheries, and which then progressed to the trunk as well. It was rapidly progressing. And on fever day 1 itself, the patient was transferred to NIID for further management. So on admission to NIID, patient had fever and complained of difficulty in breathing. He didn't have any respiratory symptoms, cough or pleuritic pain. He was ill-looking and drowsy, and he was complaining severe pain over the lower limbs, severe myalgia. On examination, he was having a generalized tender ecchymotic patch with non-blanching as well, and he showed features of acral cyanosis, especially the limbs, the lower limbs, without any central cyanosis. He was having some mild drowsiness and neck stiffness as well, but he was having a GCS of 15 out of 15. So with that history and examination, I would like to first start with Dr. Manilgama. What would you think about this presentation?
Thank you, Tisara. Thank you for your case presentation. The first patient has admitted with fever for 1 day duration with maculopapular rash, so when a patient comes with maculopapular rash, it could be anything, could be viral exanthema, or depending on the severity of the disease, we may have to think of bacterial illnesses like when there is a fever with rash, we may have to think of sinister diagnosis like meningococcal disease, and typhus is also possible in this scenario. And considering the patient being prison guard, so the meningococcal infection, we need to think the possibility. And on examination, and by the day 2 of the illness, patient has developed tender ecchymotic patches, then the diagnosis of meningococcal is more likely, and patient also has got mild drowsiness as well as neck stiffness, which are suggestive of meningism, even though the patient has a GCS of 15 out of 15. So this is basically patient has, when a patient comes with fever and rash, it's a syndromic approach where we look for what could be the focus of the patient, the illness. And here the focus wise, it only says patient has severe myalgia and body aches and arthralgia with fever that is suggestive of meningococcal disease. So considering being a prison guard, I would consider this is as a meningococcal infection and treat quickly.
Thank you, Dr. Manilgama. Dr. Vishnu Rao, do you have anything to add to what Dr. Manilgama?
Yes. So this is how I approach the case. So first thing is, what is the syndromic diagnosis? This is an acute presentation within 1 day. The patient clearly has signs of meningoencephalitis. So this is a meningoencephalitis syndrome with the ongoing rash. So that's how I frame my differential. So now what are the things which come from the community and cause meningoencephalitis, and what can cause rash? So number 1, obviously meningoencephalitis and rash, definitely you think of meningococcus. Meningococcus is the number 1 possibility. Now, number 2 is that in India, if we see this kind of rash, typically we think of one more differential called as Indian tick typhus or Botrytis fever. The other panelist was already telling. So in rickettsial, we have scrub typhus, we have Indian tick typhus. Scrub typhus also can cause meningitis, also can be as rapid, but it generally doesn't cause this kind of rash. Now, the rash which looks like purpura fulminans, and it can cause meningitis, it can cause thrombocytopenia, it can exactly mimic like this is the Indian tick typhus. The only point little against this is that Indian tick typhus won't present, unlikely, not that it won't. In general, it takes some time to present. Patient have fever for a few days, then the rash starts, and that's how they progress. But you cannot, because now that since we are talking about meningococcus, when I see this patient in the emergency as the first one, I would consider Indian tick typhus also. So number 1, meningococcus. Number 2, Indian tick typhus. The other differential I'll keep in my mind is chikungunya. Now, you can say that how can chikungunya? Now, we have a chikungunya outbreak happening in India, where typically an elderly patient comes like this with an acute meningoencephalitis and the rash peripherally. The other possibility is that chikungunya can cause very well encephalitis, especially in elderly, and the rash would be peripheral, which I have shown you. The other disease is the enterovirus. There are certain enterovirus which can cause this kind of rashes, but however, if enterovirus generally there's not much treatment that we're going to give. So, and the other differential is the drug rashes. So all these I'll keep in the list of my differential diagnosis, but the way it is progressing appear to be, since its way it is progressing is rapid. So I'm going to start this particular patient on a combination of ceftriaxone, doxycycline, and a steroid, and see, and then further parallelly work.
Thank you, Dr. Rao. So I would like to go ahead with the examination findings. He was having a respiratory rate of 40 to 50, tachypnic with saturation of 98% with 6 liters of oxygen. And he was tachycardic without fever, and the blood pressure was holding up around 110/85 with noradrenaline 0.2. And the CRFT capillary refilling time was more than 2 seconds, specifically on the toes. So this was the rash when we received the patient. So they informed us about this patient before transferring. So they told that the patient was having few petechial rashes, but this is how we got the patient. Anything you want to comment about this rash, Dr. Vishnu?
Yeah, I mean, this is classically the purpura fulminans kind of rash, what we see in the meningococcal infection. And now, if I see this rash, my differential narrows down to 2. Number 1, as I told you, meningococcus, and number 2, it is Indian tick typhus also exactly looks the same. The rash of Indian tick typhus, mind you, it looks the same. Number 2, and even it can involve the palms. And the third thing is that it's not only the meningococcus that can cause purpura fulminans, even at times pneumococcus, E. coli, pneumococcus and certain gram-negative endotoxemia can also cause. So when I see a patient very sick, you try to always cover blood and send the cultures and then narrow it down. But these are the other things which can cause it. And other certain non-infectious conditions like catastrophic Appler syndrome. We have seen vasculitis or catastrophic Appler syndrome also presenting like this. But the way it is progressing appears to be more infectious. So this is what I'll keep in my mind first.
Thank you. So we'll go ahead with the investigations. So on admission, because he was taken to the ICU directly because he was very ill-looking and was needing iron drops. So the blood gas showed pH of 7.4 with lactate of 7.3, PCO2 washout 14, and bicarb of 11. This is a VBG. And the chest X-ray we took on admission didn't show any features of air bronchogram or any consolidations. And the WBC count was 18,000 with predominantly neutrophils, and hemoglobin of 13.6, and platelet was 40,000. And the liver functions, INR was 2 with little bit elevated bilirubins as well. And serum creatinine was 168 with CRP of 301. With these investigations, what would you think, Dr. Suranga? What should we consider now at the moment acutely?
Yeah, looking at the VBG, the marked it shows lactate is very high, 7.3. So there is sepsis, ongoing sepsis. And looking at the pH is towards the 7.47. It's towards the normal upper limit. But bicarbonate is very low. So patient may be having metabolic acidosis compensated and overcompensated with hyperventilation. That is that's how I can interpret the VBG. And then when looking at the chest X-ray, that is completely normal though. So it's almost normal. And the hematological, it shows neutrophilic leukocytosis, and also the platelet count is low. Platelet count low partly may be due to sepsis, and also the probably the ongoing meningococcal infection with later developing DIC also may be responsible for low platelet count. And looking at the liver functions, INI is high and bilirubin is high. Both may be due to part of sepsis, as well as INR may be high due to ongoing DIC already set up in the background of meningococcal infection. So those are the my interpretation of those investigations.
The blood picture actually showed very occasional RBC fragments and the comment and a neutrophil leukocytosis with toxic granulation, and the comment was could be due to sepsis with DIC. I would like to ask Professor Lalindra, what would you think about the blood picture and the INR values? And
thank you, Tisana. So, as was mentioned earlier, in a patient with sepsis of this extent, having all these abnormalities in the blood are also possible purely due to the sepsis. Thrombocytopenia, obviously neutrophil leukocytosis, involvement of the liver impairment with high INR and the high bilirubin. All these could be purely due to the fact that there is severe sepsis going on. However, when fragments are seen in the blood film, this is something which we don't see purely with sepsis. There needs to be some reason for these fragments to have come up. We need to consider whether there is a microangiopathic hemolysis, and obviously DIC seems to be also part of the differential diagnosis. So,
thank you. Dr. Vishnu, do you have anything to comment on the blood picture and the rest of the investigations?
No, it is, for me it is fine, meningococcal with septic shock.
Okay, thank you. So, so initial management was we started IV ceftriaxone 2 gram 12 hourly with blood cultures, following blood cultures, and started on IV hydrocortisone septic dose as well. And because of the INR and the blood picture findings, we started on FFP 15 ml per kg. Disease notification was arranged and pain management was undertaken, and we actually we gave a lot of fluids as well, just for the hemodynamic status, and we tried to taper off noradrenaline as much as possible because of the peripheral cyanosis. Anything, Dr. Vishnu, I would like to ask, what do you think about the antibiotics, FFP, steroids specifically?
Yeah, I agree with, so my comment will be on antibiotics, definitely agree with the antibiotics. Probably, as I told you, since we are talking about meningococcus, I would have given doxycycline, as I told you. See, the point here is that whenever a patient comes in septic shock, the first thing is each hour delay in antibiotic mortality will increase the, delay in antibiotic administration increases the mortality. So since my differential seal, I don't know what bug it is. So I would have given this patient IV doxycycline. I'm not sure how common is Indian tick typhus there, but here I would have given definitely a doxycycline along with it, number 2. And number 3, agree with, because the patient is in shock, he requires stress dose of hydrocortisone. So I generally don't be very narrow, 100% sure shot at initial, because it's always, patient is very sick. I'll try to be little broad, I'll cover the other differential till I know my cultures are back.
What about the FFP? Do you agree with the transfusion of fresh frozen plasma?
Yeah, I don't have any disagreement with that. And let me be very frank, I generally don't manage this. My critical care guys will take care of it. So I generally leave it to them.
Professor Lalindra, would you like to comment about the FFP?
Yes. So, I mean, FFP, as we know, is something which sometimes we use frequently to correct things like INR, if there are bleeding tendencies and all that. But I think there's more and more data coming out now that FFP can be actually more deleterious than being helpful. I think if we maybe look at the reason why this was given is because we thought it was probably DIC, isn't it?
Yes.
Can we just look at maybe the pathogenesis of DIC in a patient with sepsis? Although we use the term, umbrella term DIC, we need to be clear about the pathogenesis of DIC, because DIC, although it's an umbrella term, doesn't occur in all patients in the same way. Especially DIC due to an infective cause. So sepsis causing DIC can be different to DIC being caused by, for example, trauma and so on. And it's a fairly complex multifactorial thing. We need initiation, of course, of some sort of a driving initiator, and then it's a balance of all these different parts of the inflammatory process and the clotting process, the endothelium, complement, as was mentioned by Dr. Rao, platelets, and the fibrinolysis. If you look at all these, and we saw Dr. Rao's lecture about inflammation. Here is a patient who has a severe infective process resulting in inflammation. And then, maybe if we go on to the next slide, you can see there the two things I have highlighted there. Everything starts off, the coagulation cascade is kicked off with tissue factor. And you can see in the tissue factor, starting off this whole process is, you can see the bacteria entering. So if you think that meningococcus or any other bacteria, especially the gram-negative bacteria, they enter the circulation. These bacteria give rise to what are called pathogen-associated molecular patterns, and these will stimulate the monocytes. And this has been shown also in meningococcal infections, that the monocytes are the cells which express most of the tissue factor on their cell surface, and this initiates the coagulation process. The contact factors like factor 12 also contribute to this, and so if you can sort of go forward, it will highlight the bacteria. Then the next one would be the pathogen-associated molecular patterns. Then the next one will show you the monocytes with the tissue factor, and all this end up with thrombin. If you go one more forward, thrombin, which causes the blood clot in the microcirculation. And the next slide, please. And this, if you look at this, there is DIC where there is a thrombotic phenotype, and in most infective causes or infective cases, it is this initial thrombotic phenotype that you get in when it goes into DIC. And then with this thrombosis, we saw in Dr. Rao's lecture where there is hypoperfusion, which is made worse with the hypovolemia. There is hypoperfusion of organs like the kidneys and the heart and the liver and so on, and there is organ dysfunction. When this thrombosis is widespread, that consumes the coagulation factors and the platelets, and that is what results in bleeding. Now, in the pathophysiology of DIC in meningococcus, you can see in that corner there, at the beginning of the diagram, that protein C, which is an anticoagulant, it's a naturally occurring anticoagulant, is at very, very low levels. And because there is no anticoagulant effect, thrombosis becomes more prominent. Whereas if you look at the bleeding type of DIC, which has been put down there, like trauma and all that, it is more fibrinolytic. And that's why in a trauma situation, we say that the early instituting of tranexamic acid to prevent fibrinolysis, there are many trials that have shown that would be the first thing to do. Whereas in a infective type of DIC, we would not give tranexamic acid, but there may be a place to improve the circulation. So if you look at this on this table on this side of the slide, initially there is what is called an overt DIC or sepsis-induced coagulopathy. Now in sepsis-induced coagulopathy, the platelet count might be marginal, but you may not get a significant change or alteration in your clotting factors. This is fairly difficult to pick up, but that low platelet count is something which we need to keep in mind. Not a very low platelet count like you saw in this patient, but a marginally low platelet count. And then it goes on into the thrombotic DIC in this patient, and then of course when everything kicks up, it goes into the bleeding type of DIC. So FFP, we need to be cautious about giving FFP to correct the laboratory investigations, because we may be adding fuel to the fire by giving FFP. So that is my take on giving FFP in this patient.
Thank you.
Just a word about purpura fulminans. Now, as Dr. Rao mentioned, purpura fulminans is seen in different types of infections, and the infective causes or acquired causes of purpura fulminans, I think the commonest type of infection is meningitis, and one of the reasons why it affects the extremities is probably due to the fact that the extremities are poorly perfused, due to the fact that there is sepsis, it reduces perfusion, and there is no collateral circulation in that area. So that's the reason, one of the reasons why you get this digital type of gangrene and so on in purpura fulminans. Thanks. And as we heard before, the endotoxin in this condition can cause activation or reduction of the protein C and S levels, especially on the endothelial cell activation, and therefore it can lead to the microthrombosis with consumptive coagulopathy. Thanks.
Thank you. So coming back to our patient, so on the next day, following day, we repeated the test, which showed a hemoglobin of 9.9, which was earlier 13.3, platelet of 33, WBC of 35,000. Since there was a drop in the hemoglobin and the blood picture findings, the INR, we thought of continuing the FFP, and we transfused platelets and red cells as well. At this moment, because of the bleeding risk, the heparin was not initiated. Anything about that, Professor Lalindra?
Yes, so I think this is reasonable, because at this point I think we were not aware of what was going on, and we know that in meningococcal septicemia there is a severe deficiency of activated protein C, and although the evidence is very scant and I don't think it's regularly used now, giving activated protein C has been an option in the past in patients with severe meningococcal septicemia. In Sri Lanka, we have no alternative. We don't have activated protein C. So if someone wants to replenish protein C levels, then it is FFP that can be used. FFP is the only source, although as I think Dr. Rao also alluded to previously, there is no evidence to say that that will increase the improve the outcome of the patient. But if someone wanted to give FFP to, if someone wanted to replace protein C, what we have available is just FFP.
Thank you, sir. So back to Dr. Rao, like what would you think about the management here with the bleeding tendency? So usually we expect a thrombotic tendency, but here we have some evidence of bleeding as well.
I mean, just wait and watch, wait carefully, see how the things go, because I don't, I'm not in favor of giving activated prothrombin C, protein C concentrates or anything. We'll just hold tight, wait and watch is what I will do.
Okay, sir. So the few hours late, actually towards the morning, so this is 72 hours from the admission. So this is what actually the limb looked like. It was very much cyanosed, peripheries were very cold. Patient was actually having a very severe pain. We had to start him on a morphine infusion as well, low dose. Dr. Vishnu, what would you think now? What would be the next step?
No, I'm worried. His legs are turning black and he's going into gangrene.
Okay, so because of the increasing coldness, peripheric coldness, saturation was not detectable in the peripheries. We started with the FFP, unfractionated heparin as well, with APTT monitoring. Prof. Lalindra, anything?
Yes. This is clearly poor perfusion in the peripheries, most likely due to either microthrombi and I mean, we need to heparinize this patient, otherwise we're going to lose the limbs. So we know that this entire process was started due to the infection. So while I think treating the underlying cause is the most important fact in any type of DIC, while the antibiotics are going on, in this patient, giving some sort of a anticoagulant would be important at this point of time. Again, blood products, due to the fact that he had a significant acute drop in the hemoglobin, is definitely indicated, because he could have had some concealed bleeding due to the fact that there was a coagulopathy and the platelet count was reduced. So again, FFP is, it's a bit controversial, but I think anticoagulation at this point is something which I would have started, yeah.
I would like to ask from Dr. Suranga now. At this point, now we were worried about the notification, the contact tracing, because this patient all of a sudden came to us from another tertiary care hospital. So, Dr. Suranga, what would you like advise at this point with the public health point of view? I know it's not the clinician part, but we have to actively engage in the public health point of view as well.
Yeah. Yeah, a notification is very much important here. So the best way, the way we do it in our hospital is visually, we have a separate PHI in the hospital, so we can inform the PHI, the hospital PHI, through him do the contact tracing. The contact tracing should be done, and the chemoprophylaxis should be given for all the contacts. Otherwise, this will be like a wildfire. This will be going on among other patients, other people also. So it's a must. It's very important for our junior doctors to notify this as soon as possible when we diagnose the patient, and do the needful. Yeah.
Coming back to Dr. Vishnu, what would you like advise the health care staff with relative to the the precautions and the isolation? Are there any because we know that's a droplet transmission, so anything you want to add there?
Yeah, two or three things at all levels we need to understand. See, first thing is when this patient has come to the ER, whoever are the close contacts, generally, the recommendation is to give a prophylaxis to someone who is very close contact. Typically, if it's a healthcare worker who is done intubation or who is in close contact, or who is intubated, and the nurse who has done the aspirations of the secretion. So essentially, very close contacts require prophylaxis, number one. Number two is that isolation. See, generally, within 24 hours, all you require is a droplet isolation for 24 hours. See, this is not an airborne transmission. This is a droplet transmission. So essentially, droplet transmission refers to you require larger particles for it to transmit. So these are larger particles which doesn't travel longer duration. So they come within only 1 to 3 meters. So all you require is a single room. Somebody who enters inside should wear a mask, strict hand hygiene, and prophylaxis only to those who are close contact when it comes to the doctors. Now, if this patient has come from the other hospital, we're going to even inform the other hospital and inform about the case. And if anybody happen to have very close contact, the healthcare, the emergency people who are in close contact should receive prophylaxis. Ideally, prophylaxis should be given as early as possible, and possibly within 14 days. And the other thing is that here, one of the few other things is that once we grow the culture, we need to even identify what serotype it is. Because if this patient has come from prison, if I'm not wrong, this patient has come from prison. Somebody who's in the, I'm right? He's come from prison, right?
Yeah, he works as a prison guard, actually. Yeah.
Okay, he comes, so that's, all those close contacts, his family members, all the family members should require prophylaxis. Somebody who received him and close contact in the emergency room should require prophylaxis. In the hospital, at least 24 hours of droplet precaution. Next thing is identify the sero grouping is also more important, because if you can't, because even in the study which I have shown you, which is published from Sri Lanka, 4 to 8 cases have come from the prisons. So if you identify a particular serotype, you can vaccinate others to avoid a massive outbreaks in a particular prisons because they are all close together.
What about the prophylaxis antibiotic? Would you, because actually in this patient we actually gave ciprofloxacin as the prophylaxis. Would you agree with that, or because of the ciprofloxacin resistance?
Resistance is a problem in India. In India, I wouldn't have given prophylaxis ciprofloxacin, but at least in the case reports, what I have seen in the Sri Lanka in 12 cases, and I don't know about the current scenario. If it is sensitive, ciprofloxacin is good enough. But if you have any doubt with the sensitivity issue, at 250 mg of ceftriaxone or a rifampicin, both should be fair enough.
Right. Thank you, sir. So, come back to the patient. So. We at NIID, we don't have a ROTEM, but from another tertiary care hospital, we got the ROTEM down actually at the end of second day. And this was the ROTEM report. Prof. Lalindra, you want to comment on the ROTEM?
Yes, so ROTEM, I think all of you all are aware of ROTEM. It's basically a test of global coagulation. It tells us what the net effect of the coagulation is in the circulation, and this can be quite useful. For example, I'm not going to go into the details of this, but these plots seem as if the patient is having a procoagulant or a hypercoagulable state here, as seen by these. Now again, this could have been caused by FFP. So therefore, or it could have been the disease itself, because we know that there is thrombosis. The thrombosis is active in this condition. So therefore, I know it's not available freely, but sometimes it's best to guide our blood product administration with some sort of a thing like this. So for example, if we were able to have got a ROTEM tracing as the patient came to hospital, that may have been able to give us a little more guidance on whether this patient was having more of a bleeding tendency or a clotting tendency. So therefore, these tracings are more in favor of a prothrombotic state, and therefore, because clinically also the patient is having now gangrene with hypoperfusion of the peripheries, heparin is something that we would administer.
So with that ROTEM findings, we stopped FFP and unfractionated heparin was continued. So by the time the blood cultures didn't show any growth, because of that we sent the meningococcal PCR, which came as positive. At that time we discussed with our medical research institute, and there was no facilities to do the serotyping, and the throat swab culture and ABST also showed no growth, and the rest of the cultures were also negative. The cyanose lower limbs gradually started blistering at the end of day 4, early day 5, and patient was still complaining of severe pain over the both lower limbs. Dr. Rao, would you like to comment about the management at this point? Do we want to add another antibiotic or any other alternative treatment?
Nothing. Adding antibiotic not going to help in any case, because this is sensitive. I'm assuming that ceftriaxone, it is sensitive in most isolates, and I don't think it is the problem is with the antibiotic. I don't really think adding antibiotic help. Probably what I had one thing is that I don't have any other proven ways to prevent this, but one thing probably we can think is now these days a few of our ICU colleagues started using these endotoxin filters for our bad gram-negative septicemias. Where you don't have data. Let me be very frank. You don't have data to support the usage of this. But here, everything, it is not about the resistance to the bug. It is about the toxin that is the problem. That is the liposolis, that is the endotoxin that is the problem. probably these kind of patients, if you try to use these endotoxin filters, which typically you put a CRRT machine and you put this toxin removal, and maybe that is something probably, since you have increasing cases, that to be looked into. But otherwise, I can't really think anything. Adding antibiotics and all will help for this patient at this particular point.
Okay, thank you, sir. So we were helpless at that time, and the both lower limbs showed very low intermittent waveform with low pulse saturation. So with that desperation, we tried IV immunoglobulin. So we gave 2 gram kg dose over 2 days as an infusion, and meanwhile the heparin was also continued. Dr. Rao, would you, is there a place of immunoglobulin and plasmapheresis in meningococcal sepsis?
Not that my knowledge goes, no, I don't think, there's no data, not been much tried. These are all desperate measures, and if you happen to use this, we need to generate the data on these particular cases, but I personally think unlikely to help. Probably, as I told you, probably since the main pathophysiology is the toxin-mediated event, in this kind of patients, probably early use of endotoxin, will it help, is something it's striking my mind. But as far as the data, when I reviewed, all these did not really help much.
Okay, thank you. So these are the repeat investigations. So the hemoglobin earlier dropped, but it then became stable. The platelet count started to rise, and the INR also became stabilized, didn't go up, and the CRP was also coming down, apart from the limb ischemic manifestation. So fortunately for the patient, he gradually improved. Wounds were managed with the coordination of the surgical team, and we took the vascular opinion as well. The vascular team asked for a duplex, which showed normal major vessels up to the dorsalis pedis, and the wounds also gradually started to heal and started to reepithelize. So he was able to walk, and fortunately the patient didn't need an amputation. Dr. Vishnu, you want to add anything here? Is it when would you consider going for a surgical opinion, amputation? Because are we going to wait till the demarcation develops between the gangrenous tissue?
Yeah, once if the ischemia develops, and they typically wait for the demarcation and go for the amputation, but it depends on the clinical scenario. If the patient is in really bad septic shock and is not getting better and slings are turning black, probably earlier thing is what we do. But overall things are improving. Patient who is doing well. Only that you are in what do you say? Patient is getting better overall. Probably that is the case where I would wait for the demarcation to happen. But if the patient is really sick, progressing bad, probably that is the thing we may have to do.
Okay, thank you. So I thank Professor Lalindra for being the expert panel for this case, and we'll move on to the next case discussion, case 2, in the interest of time. It's a 70-year-old woman presenting with fever and severe body aches. So she came with fever for 3 days, severe body aches and generalized arthralgia from day 1. She also complained loose stools, few episodes per day, but she didn't have any headache, urinary symptoms or respiratory symptoms. There was no muddy water exposure. The past history of hip surgery was there, but no further details were obtainable. So these were the examination findings. The patient was alert, ill-looking, no paloicterus, not dyspneic. Pulse rate was 90, BP was okay, no cardiac murmurs, lungs clear, and the abdomen was soft. And this is what the fever chart showed during the first few days. I would like to ask Dr. Suranga, what would you think about regarding this patient when you think about the syndromic approach to for the differential diagnosis?
Yeah, this patient is 70-year-old elderly patient coming with non-specific symptoms and having features of sepsis. So according to the history, there is no any focus of infection can be identified. And even during the examination, did you mention anything about meningism or any meningeal irritation signs? Were there any meningism features?
No neck stiffness, no meningism signs.
Okay, so this is basically community-acquired sepsis, non-specific, and basically we may have to do blood cultures so we'll start empiric antibiotics, broad-spectrum antibiotics, covering everything, and we'll look for blood culture results when it is available, and patient is in sepsis with hemodynamically unstable, then manage with resuscitation, fluid resuscitation, and IV antibiotics. I would say that I would do when I see a patient like this.
Dr. Rao, do you want anything to add to that, what Dr. Suranga said?
Yeah, this is syndromically, it is a community-acquired undifferentiated febrile illness. And if his patient is ill looking, I'm assuming that patient is admitted and patient is in sepsis. So it is an acute undifferentiated febrile illness with sepsis syndrome. Now, what are the possibilities? Now, the common things I would think is what are the tropical fevers, the tropical infections, what we typically see, like dengue, malaria, scrub typhus, dengue, malaria, scrub typhus, now in this season, chikungunya for us. So these are the undifferentiated febrile illness. Number two is the a typical bacterial infections, which is too early for us to manifest. So what are the two bacterial infections which can present rapidly and can push somebody to ICUs is an early pneumonia syndrome or early UTI pyelonephritis. So these are the things I would keep in my mind and move accordingly.
Okay, thank you. So these were the investigations. WBC was neutrophilic leukocytosis, HB of 11.3, platelets were normal, CRP was quite high, 262 with a creatinine of 71 with a bit of hypokalemia. UFR didn't show any abnormalities. Sorry, the blood picture showed normochromic normocytic cells with mild ruler formation, and it commented as comments as favors bacterial infection. So with these investigations and the clinical picture, she was started on cefotaxime 1 gram 8 hourly, which was later changed to 2 gram 8 hourly after 4 days. She was hydrated well, and we were waiting for the blood cultures as well. Dr. Suranga, do you think cefotaxime or ceftriaxone would be the best here in this situation?
So that is with broad spectrum coverage, third generation cephalosporin. I would agree with the management of the comments antibiotic cefotaxime or ceftriaxone. I would continue with the same antibiotics. In our setup, the investigations are all suggestive of bacterial infection. So I would go with these antibiotics.
Dr. Rao, what would be your first line of antibiotic in this situation?
Yeah. What about the X-ray? Was the X-ray normal?
Yeah, X-ray was normal, yes.
Okay. That's what this clearly. This is still it is the focus we do not know. The focus is still not clear, and I'm going to send for malaria, dengue, and I'm going to put on scrub typhus, look for scrub typhus. So for me, still the differential diagnosis is a community-acquired sepsis syndrome. We are not sure what it is happening. As I told you, the other focus which I would think is the intra-abdominal abscesses and early pneumonia. So these are the things I'm going to do. So here in India, we're going to put on a cefoperazone sulbactam or a BL-BLI coverage along with the doxycycline. This is what we're going to start in India. Because in India, we have a lot of ESBLs. Other than, as I told you, if it is not the community-acquired tropical illness, if it is bacterial infection, like if there is any intra-abdominal abscess, or if it is a pyelonephritis, or it is, these are the things still I did not rule out, I do not know yet. So if the patient is stable, I'm going to put on a BL-BLI, that is either cefoperazone sulbactam or piperacillin tazobactam, and doxycycline, because scrub typhus is way common for us. We see scrub typhus all the time here. So this I'm going to put, and I'm trying to further await blood cultures and image the chest and abdomen to identify the focus and collect my dengue, scrub typhus, and all other reports.
Can I ask a question, Dr. Rao? Yeah, so
Yes,
in our setup, we don't consider typhus, that is not very common here in our setup.
Okay.
And again, the patient is hemodynamically stable, and therefore the patient is coming with non-specific community-acquired sepsis syndrome, and patient is hemodynamically stable. So do you still consider going for higher antibiotics, or So we start with triaxone or cefotaxime. If we suspect ESBL with any urinary symptoms, we consider community acquired ESBL, pyelonephritis or urinary tract infection, where we start with high antibiotics like carbapenem, and the other instances usually we go with third generation cephalosporin.
That's what. It's not about high or low antibiotic. For me, it is what is the syndrome. If you see in India, the community acquired ESBL production is 80%. That means if I have a young female who comes from the community, never been hospitalized, never took an antibiotic, come to my OP with a urinary tract infection, 90% ceftriaxone or cefotaxime doesn't work because the community acquired ESBL production in India from the community is as high as 80%. Now, if I think my differential along with, is it not lepto, scrub, or if other than that, if I think still because my focus is not clear and I still don't know what is happening, whether the patient is in the ward, I do not know. If I want to cover my gram negatives here in India, we need to give BLBLI. If I think the syndrome is only gram positive, I would be very, for example, if I think it is a pneumonia, here is also the commonest is pneumococcus, 99% will work pneumococcus. So I would have put ceftriaxone and doxycycline because we have mycoplasma also. So if my syndrome is pneumonia syndrome, if the patient is in ward, yes, I'll give only ceftriaxone and doxycycline. If my syndrome is a urinary tract infection and if the patient is in the ward, the commonest organism is E. coli. For us, 80% is the ESBL production. So I'll be putting on BLBLI, that is cephalosporin sulbactam. And if my syndrome is in the meningitis or meningoencephalitis, here in India also it is pneumococcus, meningococcus are the commonest organisms. So it is ceftriaxone and vancomycin. So based on the syndrome, what I am thinking, what are the probable bugs? What is the predicted mechanism of resistance? That's how I choose my antibiotics. Here, I still don't know what it is. My other differentials is because the urine is normal, the blood cultures are awaited, elderly patient CRP is high, the X-ray is normal, counts are high. So it appears to be a pyogenic focus. So either it is a tropical infection versus, is it a direct bloodstream infection or is there any intra-abdominal abscess or is it a subsegmental consolidation which not seen on the X-ray? Still, I do not know. So that's the reason I'm going to give this image and do the further workup.
Okay, thank you. So the echocardiogram, the urine culture, they were all negative, but the fever persisted, and the patient was complaining of severe right ankle joint pain. Earlier, she was complaining of severe generalized arthralgia, but now she was pointing to right ankle joint. So with that, it was a clear monoarthritis, but there was no restriction for passive and active movements when on examination. And the blood culture, there was a signal of gram-negative cocci. So with that picture, I would go back to Dr. Vishnu.
Gram-negative cocci in the blood, and no, is it a gram-negative cocci? The only thing I can think is meningococcus. Meningococcus can rarely cause ankle arthritis, ankle septic arthritis, or knee septic arthritis. But it's very uncommon thing. But still, I'll wait for the final culture to see, because at times you see the contaminants, can come. So I'm just going to wait for the final culture. But meningitis can cause, Neisseria meningitis can cause this syndrome. It's very uncommon, but it can cause.
So blood culture came as suspected Neisseria meningitis, and it was sensitive to cefotaxime, ciprofloxacin, chloramphenicol, and meropenem. And this patient is now continues to have fever on IV cefotaxime 2 gram 8 hourly. Dr. Suranga, you want to change the antibiotics at this point, or?
Yeah, according to the ABST, the organism is sensitive to cefotaxime, and we are on the correct antibiotic. But I would like to consider whether the patient has got any other infection while in the ward, like catheter-induced or cannula related infections, and would like to look for any focus other than meningococcal, already known meningococcal infection. We have identified the organism at the moment, and the other possibilities, even though at the beginning, even the organism is sensitive to cefotaxime, whether the patient has developed any resistance when we are treating along the treatment line. So I would like to consider that also. And whether this arthritis is purulent arthritis, that also can give rise to recurrence fever. Usually the arthritis due to meningococcal could be purulent arthritis, giving rise to septic arthritis, so it could be due to immune complex arthritis. Usually immune complex arthritis would happen after 10 days of duration, and so that also I keep in my mind, and will examine the joint whether there is any features such as purulent or septic arthritis. So those are in my mind. If it is suggestive of a purulent arthritis, I would like to consider joint the orthopedic referral to the joint to be washed off. Yeah, those are my differentials.
Dr. Vishnu, when would you think there's a possibility of septic arthritis here? Because this patient was having no restriction of movements for active and passive movements. So
the first thing, if somebody has a isolated joint involvement significantly and the patient is not getting better, the first thing I would think is a septic arthritis. Should we really go and debride? That is one thing I'll think of. And the other thing, other causes of fever in a patient who is hospitalized, is commonest is that just the thrombophlebitis. Patient will be walking, talking, running, and all you have is fever when the thrombos weak. And other things, rarely is the drug fever. If the patient is absolutely fine, everything is fine, it's just the drug you are common, beta-lactams are known to cause fever. But in this particular case, I would try to maximize the doses of antibiotic. And, I think if I'm not wrong, we in India, we regularly use ceftriaxones, 2 gram PDs. I think even up to 6th hourly cefotaxime, you can go up to 6th hourly 2 grams. I'll maximize the dose, and it's something, a joint. I'll involve orthopedic surgeon, and I'll see if things are not going well. Then the other thing I think is the joint. Should be go in and lavage the joint. If there is severe pain and swelling and restriction of movement, then should we go and just debride it. Source reduction is the other thing I would think in this patient.
Yes, thank you. So the patient didn't have much of restriction of movements with the ankle joint, and she could even walk also. So the surgical, the orthopedic opinion was not taken. But as the fever was persistent, we took the microbiology team's opinion as well, and they asked to add meropenem on top of cefotaxime. Dr. Vishnu, would you like to comment on the antibiotics at this stage?
It's kind of panic button. I do agree when the patient is not getting better. Did we reculture it? This patient, the next thing I'll do is reculture him. Reculture her and see if she's not clearing the bacteremia. The other problem here happened is, in general, the resistance of meningococcal resistance to third generation cephalosporin is not a common thing. But here in this particular case, this patient was lower dose in the beginning in the first 3 to 4 days. Then the dose has been optimized. Could that has caused a PBP2 mutation and caused it? Yes, theoretically it is possible. Since the patient is not getting better and the source reduction is out of the issue, I would definitely reculture. Probably by then, how many days, doctor? I mean, how many days it is now? Patient is not getting better, fever? It is now how many days now?
It's actually day 7.
And when did we optimize the dose of cefotaxime?
On day 4.
That means it's 3 days.
Yes.
Probably what I would have done is I would have recultured. Probably I would have increased the dose of cefotaxime to 2 grams 6th hourly, and I would have waited a 48 hour. On treatment resistance with meningococcus theoretically is possible when the patient is walking, talking, running. I would wait. I would have waited probably 48 hours, and then make sure that there is no thrombophlebitis, no other stuff. And also we are in endemic areas, and there are always coexisting infections. I keep telling my fellows always about this. I have a good number of patients who have come in. They also have coexisting malarias, coexisting dengues and all. So I just make sure that there's no other coexisting things like malaria, dengue and scrub and all that stuff. I presume that you already tested. That is the other thing. I would wait for 48 hours, maximize the dose, reculture, and after 48 hours, I'll take a call.
Thank you, sir. So we started meropenem and the fever settled gradually. And the plan was to continue meropenem for 7 days and cefotaxime it was omitted after day 10. Fever was completely settled, patient clinically improved, the joint pains all improved, and she was discharged home. So in the interest of time, we would go for Q&A if we have any questions on the Zoom platform.
There was one question in the Zoom platform. Is there a possibility of dual pathogen causing meningitis with meningococcal infection? I think Dr. Rao briefly addressed that question also.
Dr. Rao, is there anything you want to add? Do we have to consider dual pathology when you are present with a patient with, for example, meningococcemia or purpura fulminans?
Generally, if the patient has presented, see, everything looks like that, and this patient, for example, the first case you presented, typically the patient has, everything what he has with a meningococcus. And here I don't have a reason to suspect. But if the patient is not behaving as per the plan, for example, if this particular patient, it's 7 days, patient is not getting better, it may be just taking time to respond is one option. The other thing is always make sure the so-called, the Orcam's razor, it doesn't hold true for India is my always benefit. I have seen n number of times two things. Patient with, a typhoid and malaria in the same patient, proven, culture proven, and the smear positives. In endemic countries, always you look for the coexistent tropical illnesses, especially if the patient is not behaving as he should behave. If the patient is typically, you have patient clearly urinary tract infection, you're given the best antibiotic, patient, there is no force reduction is also come, still the patient is not getting better, then I always think, is there any coexisting pathology? Is it the drug, or is it a new thing a patient acquired? For example, meningococcemia patient, he's in the hospital, he has all the skin barrier gone, he's on all the lines, he will be, he can develop a new nosocomial infection. Yes, because this patient stays in the hospital for a little longer duration, and he's on the invasive lines and all. Yes, this patient can develop a new nosocomial infection. So if a patient comes from the community and to do dual infection always possible, always possible, especially think of them when the patient is not behaving as he should behave. And a superadded infection is also always possible when the hospital stay goes up, especially in the sick patients who requires lines, Foley's, etc.
There is one more question, Dr. Rao. Whether to start cefotaxime, the CNS dose, as soon as blood cultures isolate meningococcus in a patient. So I think the question is basically someone with meningococcemia, whether to give the CNS dose, even though it's not very clear whether there is meningism or whether there's meningitis as well.
I think the highest dose possible is the best, because we clearly know that meningococcemia, the mortality is way higher. And in meningococcemia, we have significant adrenal involvement and third space losses. One dictum is that when the patient has anything in the blood, patient is hypotension, always give highest doses possible. In a patient with sepsis, septic shock, there is a lot of third space losing. There's a lot of third space losing, and the dose of antibiotics what you give, especially the first 48 to 72 hours, should be the maximum possible doses. Especially I'll see, I have my fellows who, especially I teach my fellows about the same thing. See, if I have a patient who has come from the community septic shock, his creatinine is 3, and I see, I give the full possible doses in the first 48 hours, even though the creatinine is high, because these patients are in septic shock, and the high creatinine is because of the sepsis, and the third space losing is more, and the good amount of antibiotic what you give goes into the third spaces. So always give maximum possible dose in somebody who is septic in the first 48 to 72 hours, and please don't try to adjust the doses in the patient is in septic shock. Always the highest possible dose in the first 48 hours.
And this question also to Dr. Rao. This first patient actually came with a severe sepsis, and his blood pressure was low and he was in inotropes. And in this situation, when the diagnosis of meningococcal sepsis is confirmed, when would you suspect adrenal hemorrhage or adrenal insufficiency acute as a complication of this infection?
Sir, persistent ongoing hypotension, sir. If the adrenal hemorrhage, I mean, generally once we treat once this patient, we started on the medication, and if the other things are improving and only the hypotension is persistently there, even though the other parameters are improving, I would think of adrenal hemorrhage. And also, when the patient comes in the first event in the hypotension, I'll think that the adrenals are involved. But I'm not sure whether the adrenal hemorrhage is there, but I'll assume that his adrenals are also involved. I'm going to start aggressively. And say after 4 or 5 days, if other things are improving, things are getting better, but the hypotension is persistent, then I would think that is there any coexisting adrenal insufficiency because of the adrenal hemorrhage?
Right, thank you. I think,
Okay, that brings to the end of our panel discussion. I thank Dr. Vishnu Rao and Dr. Surangamanilgama and Professor Lalindra for your contribution.
Thank you, sir. I cordially invite Dr. Vimalasiri Uluvathage, the convener of Infectious Diseases Forum, Ceylon College of Physicians, to hand over the certificates of appreciation to the resource persons. I invite Professor Lalendra Gunaratna, Professor and Consultant Hematologist, Faculty of Medicine, University of Colombo. Next, Dr. Thisara Pereira, Acting Consultant Physician, National Institute of Infectious Diseases. Thank you, sir. To conclude today's session, I invite Dr. Nilanka Pereira, Joint Secretary of the Infectious Diseases Forum, Ceylon College of Physicians, to deliver the vote of thanks.
Thank you. So I would like to actually take this opportunity to thank all our resource persons. Dr. Vishnu Rao from Hyderabad, India, who joined us online to share his expertise and his views on meningococcal infections, as well as our local experts, Professor Lalindra Gunaratna, Dr. Surangamanilgama, as well as Dr. Thisara Pereira for conducting the case-based discussions. I would also like to thank our sponsors, CCL Group, for supporting our CME session today. We hope that you will continue to join our monthly sessions in the next few months as well as probably join our conference, which will be held on the 12th and the 13th of June this year. Thank you.
Thank you, Madam. With that, we conclude today's Infectious Diseases Day, organized by the Infectious Diseases Forum, Ceylon College of Physicians. We would like to invite everyone to join us in March for the next session, which will focus on gram-negative sepsis. Thank you and have a pleasant day.